Melanoma Matters is an educational resource. The content represents our opinions and does not constitute medical advice. If you're a patient with questions specific to your situation, please consult your medical practitioner.
Hi, everybody. Welcome to Melanoma Matters. I'm Sapna Patel.
And I'm James Larkin. Hi.
Hi. And obviously today we have a special guest live and in person, at least for one of us. Sorry, James, that you couldn't be with us here. We have special guest Toni Ribas joining us today. Toni, thank you for agreeing to be on our podcast.
Sure. My pleasure.
We're trying to figure out how not to get a lot of background in this, but, you know, it's raw. It's fine.
Mm-hmm.
Toni, I just wanted to, for our audience members, what we normally do is ask people about their background and their training. I wanted to tell the audience about how I first met you. It was 2011, and Kevin Kim had been, at that point in my career, introducing me to many wonderful people. In 2009, he introduced me to Kim Margolin, and he said, why don't you come to a SWOG meeting? These are really good. You'll get to meet other people. You'll get to interact with Toni, who's committee chair. And so I started coming kind of slowly, and then I remember presenting a temozolomide ipilimumab proposal that we had done the trial in Houston and had some interesting results. And, you know, it's a good experience for a young person to present a concept and get feedback, whether it succeeds or goes through or not. And then in 2014, I think you and Ken Grossman rang me and said, look, we'd like you to be co-chair of this big adjuvant study, which was a real honor. And then in 2018, you sent me an email and said, you know, we think you've done a nice job on this 1404 study. It's time to think of the next one. And you very, very graciously, you know, sort of gave me free rein to think of what that next one could be. And that ended up being, James, that was S1801. That was the S1801 one. And then when that one had the big presentation and had a finicky discussant at ESMO, we had a little dinner reception, only teasing. We had a dinner reception, and Toni, you weren't able to make it, but you FaceTimed in, and I was a mess. I was just waterworks for that, because what you said was so special and powerful. It was, you know, about how what we were doing was changing practice for patients. And it was just really so nice of you to do that, and what you've meant to me in this my career and helping me through this kind of SWOG ladder, as it were. Anyway, Christian was next to us. He was there for the toast, and he was having to console me. It was really just a pile of tears after that. But anyway, that's you know, that's just like one of many Toni Ribas stories I have over the years.
Well, I'm glad you're sharing, because you're sharing recent melanoma history and how things are, have led to where we are. And first, it was a great choice to ask you to join our group at SWOG. It was an outstanding choice to ask you to be involved in the adjuvant trial. And then when the new adjuvant came, I tried to look back on those emails. Where did that perfect study design come from? Oh, wow. And I'm puzzled how we all got to something so simple and so nice.
Yeah. As I said on a committee meeting a couple months ago, James, I said, you know, S1801 was not the sexiest trial.
It was the most sexy trial that you could ever find. That is the so perfect simplicity. And you ask one question and get one clear answer.
Yeah.
You know, guys, I think the discussant may have actually said that. I think that was the first comment that the discussant made.
With a sexy trial. Thanks, James.
Simple yet powerful design, I think, were the exact words. So congratulations. So Toni, I mean, before asking you a little bit about your background, I'm just going to do a personal reflection, if I may, as well. So you've always been extremely kind and generous. One of my colleagues, Nikki Hunter, actually came and spent some time with you. I don't know when that was, in Los Angeles, maybe 10 years ago or something like that. She sends her regards today. So maybe a personal reflection, Toni, on top of that. I think the first time I remember working with you was with the Cobram study, probably 2012, 2013, and Grant MacArthur as well, and a few other people. And I remember two things very clearly, actually. One was your generosity and that of Grant towards me as a quite a lot more junior colleague at the time. And then the second thing, Toni, and I don't know if I'm allowed to say this in public or not, I remember the call really clearly. It was late in Europe, and I was sitting on my laptop at home in the office kind of thing when we saw the data for the first time. And I think it was you and I and maybe a couple of other people from Roche Genentech. And when you saw the PFS curves of vemurafenib versus Vemcobi, you only said one word, which was wow. And I remember that really clearly. Anyway, so listen, great to have you with us, but I'm sure everybody would love to know a little bit about your story, your journey, where you've worked, why you're an oncologist, how you've ended up where you are today. We'd love to hear something about that if we may to start with.
Sure, and probably it's a story similar to many melanoma oncologists, which I got to it through the science. I did my residency in Barcelona, Spain, and that was in the middle of the 90s. And at that time, we're giving chemotherapy to people. I was interested in lymphoma and breast cancer, like everybody at that time. And I thought, well, might as well learn something else. I might as well go somewhere where we're doing something different. So I wrote to labs that were doing immunotherapy and gene therapy. And all of my colleagues from that time, including one who became famous afterwards, Jose Baselga, told me I was wasting my time, that the immune system could never treat cancer, that what I was doing, that was all phenomenology. And I went to this lab. I did a postdoc for a period of time. There was a surgeon, Jimmy Conomo. And then we were ready to do things in patients, to take dendritic cell vaccines to patients. Oh, well, that I can do. I can work on a protocol and get it through the FDA and the whole thing. Great learning experience. And then I stayed for fellowship. And why would I get stuck with melanoma? Well, because no medical oncologist in their right mind wanted to treat melanoma at that time. So you remember that, James?
Exactly the same for me. Exactly the same. Yeah.
So, but then we had the ability to do whatever the science brought us to, and that was continuing with immunology. And we had occasional patients with melanoma that did great. We all said, "Oh, it's the immune system." Well, we need to know the rules of the game, and that's where the work of Jim Allison started giving us the rules of the game. And then Mike Stratton and Richard Moraes published the BRAF mutation, and I was listening to a talk shortly after by Charles Sawyers, and Charles Sawyers had it in his slide and said, "Well, these mutations are the tribal mutations of cancer." I said, "Well, I have no idea what you're talking about. I do not understand what that means, but let's study it." And we looked at our cell lines, and yeah, if you block that, cancer cells didn't like it, the BRAF mutant. So that's how I just pushed myself to be able to be in the phase 1 trial of the Plexicon drug. We had done a phase 1 trial of CTLA-4, tremelimumab. Then with time came the phase 1 trial of pembrolizumab. And you may think, well, was I lucky? And probably not luck. I think it was because the science prepared us to say, well, if this comes around, those may be good treatments for patients. And that's where we're here to do, to find what can best help our patients.
Yeah, indeed. So, I mean, we've just seen an incredible 10 or 15 years without doubt. And I think many people would agree that now one of the biggest problems we have is resistance to these drugs. Obviously, they do help a lot of people. And I suppose there's two separate issues there based on what you said. There's resistance to BRAF targeted therapy, and there's resistance to checkpoint inhibitors. And there's been a lot of work on this. I mean, if you take BRAF targeted therapy, right from the very earliest days, there were some beautiful papers coming out on mechanisms of resistance. So my first general question on this may be, if we take checkpoint inhibitors, what do you think is the sort of state of the art in 2024? And what I'm kind of wondering here, these are complicated problems, obviously, is do you see a time in the future where we might have information that we can be using in clinic in terms of selecting patients for treatment based on intrinsic possibility of response or acquired resistance, or is that still sort of science fiction, do you think?
I don't think it's science fiction. I think we could do it. It's easier to try and give the treatment than wait for a test that's not going to be conclusive and then say, well, you might be better off with this or that treatment, especially if we talk about single agent and combination immune checkpoint blockade. People would just do one or the other based on their experience. The resistance to targeted therapy is because the pathways get reactivated, and that's where the CoV-BEM, the addition of the MEK inhibitor to the BRAF inhibitor, was mechanistically based and also decreased the side effects because of taking up paradoxical MAP kinase activation. I think it's hard to find a combination of two drugs, the BRAF and MEK inhibitors in general, that would do so much by themselves. And it's so synergistic and decreasing toxicities. But still, it's blocking one thing in the cancer, and the cancer has found ways to escape that by rearranging parts of chromosomes and getting new functions. And BRAF and MEK inhibitors are probably curative in early stages. In really late stages of melanoma, where there's a lot of cancer and a lot of possibilities of some cancer cells having developed escape mutations in different ways or escape pathways, that's where we struggle. For cancer immunotherapy, for checkpoint inhibitors, the immune system becomes more complicated because there has to be that the drug is the T cells that kill the cancer. Those T cells have a receptor, and the cancer has a ligand, which is HLA peptide, and this peptide is a mutation that's specific per patient. So there's part of the immunology that it's hard to assay or analyze in any way. And the resistance is either the T cells are not activated and then they're not stuck in PD-1 checkpoint, or the cancer has been so immunogenic that it tries to escape the immune system. And we're seeing evidence of both ends in patients who do not respond or develop acquired resistance to anti-PD-1.
Can I ask a question, Toni, about targeted therapy? We had a conversation on another episode. I was kind of mentioning it to Katie last night at dinner. The BRAF oncogene is immune suppressive. On its own, it does not allow as many T cells in. Some of this is, Arlene Sharp's work. And then you block it and you get T cells in. Do you think there's an indirect immune system response when you take targeted therapy? Some of our long-term responders, the patients that are still on it, is it that we eliminated all the dominant and subdominant clones of BRAF and that's it? Or do you think if we ever find a biomarker for memory T cells that we actually did some education to the immune system with targeted therapy?
One of the most disappointing things in my career was to see that the triple therapy, BRAF, MEK, and anti-PD-1, in the one larger trial was negative, and the other ones, the COBI, Atezo, BEM, was positive, but just by the sleeper. So it's a marginal improvement. There's something there. It's probably not good enough to justify putting the three drugs together and the added toxicities. I think targeted therapy is not immunotherapy. So BRAF and MEK inhibitors, when there's a response to them, there's not the hallmarks of an immune response, okay, which is a durable response in a subset of patients mediated by a persistent immune infiltrate. Yeah, there's a transient immune infiltrate, and people have shown a lot of those pictures that is probably because if you block the MAP kinase pathway, there's all this transcriptome downstream of it that includes IL-8 and other immune suppressive factors that all of the sudden is stopped, and now T cells that travel around, they just show up to see what's the party is. But those are not the antigen-specific T cells. So that's not an immune response per se. It's a non-specific change into microenvironment that allows T cells to be there for a while.
Although couldn't we hypothesize that those tumor-resident T cells are there from the beginning, and then when you block the MAP kinase pathway and all these, immune suppressive transcriptions are stopped, those maybe they do something there, but it's a very early effect, I would agree. Whether it lasts, whether it leads to responses.
I've heard a lot about if you kill cancer cells that may release antigens and it's immunogenic. Sure. And cell death, immunogenic cell death. I still don't understand what. I've read a lot of papers on it and people use it. I still haven't seen it.
Correct.
I do not know if chemotherapy induces antigen cross-presentation. BRAF inhibitors, BRAF and MEK, certainly do not. That's an apoptotic cell death where the cells stop signaling and then macrophages come in and eat them up. And there's very little of any antigen release. And I don't know if I'll make some enemies, but the abscopal effect from radiation is something that's voodoo. I wish it was there. I've tried many, many times. If it's there, it's not common.
Yeah, agreed.
Yeah, I think we all have in clinic, haven't we? And it's a shame, actually. In reality, it seems to be extremely rare. I can't remember clearly seeing it very often myself at all out of what hundreds, thousands of patients. So just to maybe pursue this a bit more, Toni, I mean, there's been a lot of trials in the refractory setting, let's say checkpoint inhibitor refractory disease over the last at least 5 years longer. And maybe this is the most diplomatic way I can phrase the question. What do you think the lessons are that we've learned from those trials? There's probably more than one lesson there, because at the end of the day, after all of that effort, what's really come out of it for patients in clinic? I mean, I guess we've got the cellular therapy data. We can be fairly clear about that. But there may be even 10, 20, 30 other trials there which have been roundly negative. Are there any? Do you think there's any themes there? Or it's just a really difficult problem and we're doing the right stuff and we just need to keep going?
I'm not that negative on all of these trials. As long as the drugs were good drugs given at therapeutic levels and there was a good hypothesis to be tested, I think we have to do clinical experimentation. There's no mouse model, especially when you deal with the immune system, there's no preclinical model that will tell us exactly what will happen. If we look back at just simply with CTLA-4 blockade and PD-1 blockade, CTLA-4 blockade does a lot more immune things in humans and in mice. It's just that CTLA-4 is not where T cells are stuck in a person with melanoma that has a chronic interaction with the immune system. They're stuck at the later checkpoint, PD-1. They pass CTLA-4 in the majority of cases. In the mouse, it's different. In the mouse, we implant the tumor and we try to do immunotherapy, so we need co-stimulation, and that's where CTLA-4 becomes limiting. So there was no way to predict that PD-1 would be much better than CTLA-4. If you had asked me 15 years ago, I would always say CTLA-4 should be more important than PD-1. PD-1 seems marginal, but that's in the mouse model. In the human system, then it becomes dominant. There's been other checkpoints that, well, maybe there's T cells are stuck in these other checkpoints. Well, it seems to not be that many, either TIM3, TIGIT, or PISTA and others. So, but they needed to be tested because the science of PD-1 blockade is mostly human science. There's the preclinical data was really, really marginal.
Yeah, I mean, Sapna, before you go, I'll just make one point. I mean, I think that's such an important point you've just made, Toni, about actually understanding this in human disease, not just in cancer. And I was doing a session, Sapna knows this, the other day in Cambridge with some academic oncology trainees. And one of the specific points I made was, if you're using model systems, are they helpful or not? And if they're not helpful, then you need to be thinking about what's happening, understanding what's happening in humans and testing new strategies in humans.
All right. Well, what I was going to make is that exact same point about model systems, which is, we often hear, the genomes are shared 98% between mouse and human and, this and that. But so what? It's the immune system that we're trying to test, and the mouse immune system and the human immune system don't reciprocate each other. So, this is really, we develop all these humanized mouse models and we're trying to do all of that. It does not seem that there's a perfect system where when we've done that, it actually even matches the data that we see in humans, right? So these human clinical trials will be our model system, at least going forward for now. And these refractory patients, we end up seeing half of the patients we give this frontline therapy to end up with resistance. And or they finish their therapy and they're not in a complete response, as we like to say, chasing a CR. So we do need something for them. We've talked pembrolizumab, whether it's a combination with VEGF, whether it's multiple checkpoints, is it going to be just the alphabet soup of checkpoints? We don't know, but Toni, I think one of the important studies we did in the last few years in SWOG was the S1616 study, right? I mean, it was really this idea of how important is that PD-1 backbone when you're in the resistant setting. Do you drop it and move on? Do you, switch over to CTLA? Does CTLA have efficacy there? I mean, I don't know how you feel about it. That was such a great study, and it was not easy to get through. Cooperative group, many people probably know it was a 3-to-1 design, 3-to-1 randomization. Some of that was this idea in that resistant population, what's the most interesting thing to test, right?
Well, so I would explain it from my side of view in another way, which is we wanted to reverse resistance to PD-1, and primary resistance to anti-PD-1 is because there's very few T cells in the tumor. So in some patients, could they be stuck on an earlier checkpoint, which was CTLA-4? Sure. So that was the idea to release. So the idea was, do we release the CTLA-4 checkpoint in these patients where the T cells did not make it to the tumor? It was all along thinking that it should be in combination. So the patients who progress on anti-PD-1 keep on anti-PD-1 and anti-CTLA-4 to reverse the resistance. Okay. Because once the T cells get to the tumor, PD-1 should be limiting, because they make interferon gamma, and otherwise they get turned off by PD-L1, which is induced by reactive expression by response to interferon gamma. But then we were forced to do a randomized trial, and we said, well, why do I need a randomized trial? That CTEP just forced us to do that. And then we did this imbalanced randomized trial because we said, well, we want to get more patients on the combination, and we justified it by having enough biopsies so we can analyze them and keep analyzing them. Like in this meeting, we're still presenting analysis. Katie Campbell is presenting analysis from these biopsies.
Yeah.
So maybe chasing a CR. Sapna, you and I have talked about that a few times, and people do talk about this idea. What do you think about that, Toni? I'm not sure we've talked about it together. In other words, we know that, say, with Ipi-Nivo, you've got a certain CR rate, and actually we should be thinking about the front end there in trying to drive people who haven't had a CR or a good PR, if you like, with other strategies, and that might be a useful surrogate for long-term outcomes. There's quite a few analyses and trials now that are making that linkage or association. But do you think that means we should be driving CRs at the start or not?
Well, our common friend Keith Flaherty says that the rate of CRs depend on how much you're paying your radiologists. If you pay them a little bit more, you'll have less CRs because they spend more time looking at it. I think it's the major response where there's only residual non-active disease left, and then that's what you're saying about CR. It doesn't matter if it's radiologically complete CR. There's with lymph nodes, we just make an assumption that what's left is the lymph node, and we don't go away. The lymph node does not go away the same as the liver doesn't go away, even if there was cancer before. So it is. I think the CR is a bar where it's hard to reach. I would think it's the major responses and how to achieve them. But that it's I don't know. I think it's looking at the tail of the curves, and the tail of the curves. So you just published the Checkmate 067, and we see that tail of the curve. Tail of the curve of Ipi in that trial is off the roof from any other trial. So I don't know what you guys did on that trial because everybody's doing that on every arm. But the combo arm looks really good.
Yeah.
Yeah. So that this might be my last question, which is just maybe slightly facetious. So where are the CR rates highest in the US? Did Keith make any comments on that? Is it Los Angeles, or is it in Houston, or is it, I don't know, Boston? Is there a league table?
Well, I think that we've democratized treatment of melanoma by developing active treatments. Yeah. And now we get the patients are responding everywhere. And all of you probably get contacts from your colleagues that are in the community that used to refer all of the patients with melanoma and say, look, I saw this incredible response. You say, we told you that happens. Just keep doing the same. There's the patients who won't respond, but there's the ones who respond. And the ones who don't respond, it's our job to come up with new treatments. I'm glad that neither one of you used terms like a patient failed the treatment, because patients do not fail treatments. We fail them. We have to think more. Our job is to understand science and develop new treatments and work with our colleagues in industry to bring them to patients in a rational way. And I think we have to continue trying, even if there's setbacks in many of the studies.
Yeah, I think that's a great point. Right, Sapna, can I hand back to you then maybe to wrap us up? Thank you so much, Toni. Really appreciate it.
Thank you, James.
Yeah, this was so wonderful, Toni. It's always lovely to hear your the way you explain things and your take on it, because you describe it in science terms, but I think ultimately also describe it in a way that practitioners and even patients really should be able to wrap their arms around these concepts. So thank you for joining us. We are so thrilled. Sorry to everybody for some of the audiovisual issues, but it's nice to be in person again. Nice to see people face to face.
Yeah, enjoy the meeting. Good to see you.